Thank you. Thank you very much. Good morning, everybody. And, I'm really thrilled to be here. I've known, like many people have known, about what T1D Exchange has been doing over these last several years, but I've never experienced being with you all. And I can really feel the energy and the meaning of collaboration and the QI collaboration that's really evolving. I think what you're doing is accelerating the process of transformation of clinical practice. And that's really a cool thing. So thanks for all your work that you're doing. What I'm going to do today for these next half hour is really, well, first of all, I have no disclosures, anything to report. I'm going to talk about the screening protocols we've employed at University of Miami Pediatric Clinic, Diabetes Clinic for really a long time. We'll also talk about the medical providers' perspectives on the screening program, as well as the patient perspectives on this, on the psychological involvement in routine diabetes care, and then review the results of a quality improvement initiative that we began really during COVID. The background I don't need to tell you guys about, but I think what's really remarkable is that even today in 2022, most kids don't achieve glycemic targets, even with increasing meter use and CGM use and pump use. And you guys know this stuff because this is your research that was published in 2019, but showing that these teenage years are very difficult for kids to achieve results, despite the fact that pump use and CGM use increased. Glycemic control remains an elusive goal. This data is more recent data from the SEARCH study, and it is very discouraging, actually, isn't it, to see that this latest cohort of kids have a mean A1C above 9%. I mean, that's like what we have to ask ourselves, what accounts for all this? And there's lots of reasons. We all know in clinic, kids don't understand the importance. They're disorganized. They have psychological problems, maybe. Their families are disorganized. They're not involved enough or in the right ways. Or just kids are more interested in having fun and doing, they're not interested and motivated for diabetes care. Or it's about us. The healthcare teams don't really know how to work effectively with kids to help them achieve these targets. So these questions have been around for 4 decades. Why is non-adherence so common? Optimal glycemic control so difficult to achieve for most patients? And how do we motivate kids and families to improve the situation? We know the answers to this, and you all know the answers to this. And, we could think about all the factors involved in the kid's glycemic control from the individual level, the parent and social level, and the medical system level, health insurance, relationships with doctors and the team, school health policies. There's so many factors. There's no single bullet. But what it means is on every individual case that we face, we have to be a detective and figure out for this kid, for this family, what is it that accounts for their outcomes? Well, psychological factors are really important. We have a lot of evidence that this is the case, and that distress is common. We know that family factors are incredibly important. In particular, family conflict can undermine all kind of efforts. And we know that supportive behaviors, clear communications, and organizational routines are associated with better outcomes. We know all that. And in fact, ISPAD has known this for many years. I've been involved with preparing the guidelines for ISPAD since 2007, I think. And at that time, we recommended routine psychological screening, but nobody was doing it back then. I can back up and tell you that at University of Miami, we've had psychologists in the clinic since 1990, but not having a formal screening program. We've had, part of the team talking with our colleagues about the patients and coming up with plans, sure. But now I think we're seeing things have been moving along, not in any, small part from the work that you guys are doing. You guys are doing a lot, I think, for transforming and getting this to be more the way that we do this routinely. So there's lots of evidence and there's lots of guidelines. And what I'm going to tell you about is the first thing, but we finally got together a formal program and got all the necessary resources that we needed to make it happened in 2018. And we published this data, I think it was about a year ago, in pediatric diabetes. So I want to tell you about what we did when we incorporated a universal comprehensive screening program. We focused on kids 10, 12 and older, and over a 1-year period, prior to their regular clinic visits, they were screened for depression, suicidal risk, anxiety, life satisfaction, diabetes, stress, disordered eating, family conflict, regimen adherence, and motivation. How did we do that? In 12 minutes, we did that, actually, using some standardized measures and building on standardized measures. The screeners were completed in the waiting room. Remember, pre-COVID, so they're all in the waiting room, and we gave them tablets. The scores, we had scoring through Qualtrics. Everything was scored immediately, a report prepared, and the team knew which kids were above predetermined cut points on any measure. Then the psychology team was immediately consulted and worked with the family to develop a plan. These were the measures that we used. I'm not going to go through everything in the interest of time, but you will see that all of these measures are published measures. We just took some liberties with abbreviating them. And that's one of the things we could talk about in terms of, and this is what it looked like from the patient perspective. They just flip through these screens, they complete it. GAD-7, PHQ-9, you all know those measures. And we had 280 kids complete the measure over the first year of the program. 86% had type 1 diabetes. We were able to screen 83% of eligible kids. And the protocol was completed in an average of 12 minutes. We knew exactly because we could measure how much when they started and when they finished. 10 months after the screening program, sorry, I want to go back to that. We found that our consultations by the psychologist in clinic increased by 25% across all the providers. And then what I'm going to tell you right now is only the type 1 kids. And you can see here the actual percentages of kids who screen positive. Well, first of all, we see 80% who screened positive for A1C above 7%, not surprising. Insulin non-adherence rates were quite high too, about over a third, about 35% of kids. And low motivation, pretty high, 50% of kids were apparently not very motivated intrinsically motivated for their diabetes management. But you can see depression was around 20%, anxiety close to that. Disordered eating was less than 10%, screening positive. Diabetes stress over 20%, family conflict around 10%. Any psychosocial elevation was 3/4 of the clinic population. So there's a lot of stuff to deal with, as we all know. We then looked at relationships of these factors to A1C, and all of the measures we chose were associated significantly with A1C in the direction we would have expected. And that's kind of like a summary of what we found. They were more likely to screen, kids above 9% were way more likely to screen positive for all of these psychosocial factors. Then we looked at the same relationships with insulin non-adherence or less optimal use of insulin. And we found basically the same kinds of patterns. And this is kind of a summary of that. So you screening positive for non-adherence and insulin use were more likely to screen positive for depression and anxiety and stress and family conflict and low motivation. So we did some regressions then to kind of like focus this a little bit better. And the final model then, A1C, we had insulin non-adherence, diabetes, stress, and family conflict as important factors. And then when we did the same kind of modeling to predict insulin non-adherence, we see intrinsic motivation and family conflict were the main things. That got us thinking about the role of the family in understanding relationships between kids who are motivated and their outcomes. And so we basically did a study that examined family conflict as a moderator of the relationships between intrinsic motivation and adherence and intrinsic motivation and glycemic control. And we had 263 kids in this analysis. And we basically just took their screening data and did some analyses with these. And we found that greater intrinsic motivation was associated with less family conflict less insulin adherence, non-adherence, and lower A1Cs, as well as lower measures on depression, anxiety, and diabetes stress. The moderation analysis was significant. So we found an interaction between family conflict and intrinsic motivation. Under conditions of low family conflict, intrinsic motivation was negatively correlated with insulin non-adherence. But under conditions of high family conflict, that relationship was wiped out. So that kind of makes sense, in a way that family conflict is present. Even a kid who's motivated is going to be undermined. The moderation analysis in predicting A1C was not significant, nearly so, but both of those factors individually predicted A1C. So these findings indicate, in total, that comprehensive psychosocial screening can be integrated into routine care pretty well. Now you all know that. You knew that before. You didn't need to hear me say that, but we found that in the last several years. And a very high percentage of kids do screen positive for psychological problems and family conflict. Association of these problems with glycemic control and insulin misuse supports the need for routine psychosocial screening. And of course, we could say there's more research needed for some of the screening tools, which we abbreviated. But the family conflict stuff was pretty interesting to me because I think it clearly presents a major barrier to effective diabetes management, even in kids who report being motivated to manage their condition. So interventions that address adherence issues in this population should incorporate a family-based approach to reduce conflict and improve communications around diabetes and promote collaborative teamwork in families. It also suggests that just interventions to promote and increase motivation is important as well. We then looked at the medical providers' perspectives on the screening program itself. And we just published this paper, I think, this year, actually. And this was done as a qualitative study in which we used or recruited all the providers in our clinics, 7 of them, 2 CDEs, 2 fellows, 3 attendings participated. And essentially, they were very positive about the program, indicating that the screener helped them identify problems that would have gone unnoticed, supported treatment planning, encouraged empathy, and it brought problems also to the caregivers' awareness. They may not have known that their kid was reporting anxiety and depression. The challenge, what they noted was that there are kids who slip through the cracks on busy clinic days. It is a challenge logistically to get all kids who are coming to clinic to screen. And there are some concerns that kids may not even answer accurately or honestly. But we got good suggestions from our team, which included better communication about the kids that need screening, more kind of discussion about the screening procedures for all the staff. And that includes the frontline staff as well, who are checking the kids in, who actually their job at first was to hand out the tablets so that they could do the screening. And better inclusion of every member of the team, really. These are just examples of the kinds of things that team members would say. It's really nice when we know the screening results before we go into the visit, because it helps you really better assess the medical issues as well. Sometimes it picks up on why we may not be doing something. So I'm making a plan, but it's not a realistic plan because they're not capable of doing this even at this time, given the kinds of problems the family's experiencing. So then that's okay. I got to shift gears and make a different plan. So this is, I think, a way that we can see how these results are being integrated really into the care plans. And interestingly, the providers did say that the screener encouraged them to express more empathy with their patients and allowed, again, the providers to help the patients gain insight into their difficulties with self-management. Well, we then we wanted then to see what kids and parents thought about this as well. So we did another qualitative study. And again, this was just recently published. What journal do we publish this in? Pediatric Diabetes, it looks like. Yeah. So we had a group of 15-year-olds on average. 77% of the moms had college degrees, so it wasn't completely typical of our clinic, which has the full range of socioeconomic status and education. But we had qualitative interviews with 13 dyads, but we interviewed them separately and then conducted thematic analysis of the transcripts. And we were really looking at 4 issues. What's the role of medical providers in addressing psychosocial concerns? What are the barriers to discussing these issues during visits, during medical visits? What are the reactions to routine psychosocial screening procedures and consultations with the psychology team in the clinic? And the issue of accessing mental health services outside of the diabetes clinic? Because even our psychologists who are maybe have 20 minutes to consult with a kid, and they're not going to solve all the problems of what that kid has got going on, and all of a sudden magically this kid's going to improve all their diabetes management. So they need additional services outside of the clinic visit. And basically what we found was that, as indicated, it's a little busy of a slide here, but that parents and kids really felt that medical providers did have a role that routinely should address these issues about stress and about all the other issues in terms of psychology. So in fact, they felt like not considering mental health as part of routine diabetes care is really wrong. And it should be actually the case that it's normalized as a routine part of care. There are some barriers that families talked about: too many people in the room, not having privacy. And we have to be sensitive to these kinds of issues during the clinic visit. Providers being too rushed, or maybe not being interested in the non-medical aspects, because some of them feel like, well, they don't really want to hear about this, so I'm not going to tell them about it. Or even just taking, feeling that they're maybe being judgmental in some ways. Or having a history of some negative interactions with any of the healthcare team. That was kind of a barrier as well. It doesn't make you want to share all the stuff that's happening in your family. But the reactions to routine screening were very positive overall. And kids who need more support feel more valued and cared for, actually. Adolescents actually liked using the screener because it provided an option for them to disclose their concerns without having to talk with somebody, with actually not having to look somebody in the eyes and say, hey, this is what's going on with me. There was some concern that parents have that questions are a little bit scary sometimes, or kids, who weren't depressive, might feel like they're depressed because they're filling out a screener about it. Those are kind of normal concerns, but they're not really. We just have to reassure people that filling out a questionnaire doesn't make somebody depressed. And concerns that the kids may not answer honestly, that came up as well. The teens actually gave a good kind of suggestion about, well, talk with me about the screener before you just hand me this thing. So I got to have a little bit more awareness about what we're doing here, and that would promote more trust and more comfort with the whole process. Mothers, interestingly, suggested that they should be doing screeners about their kids, but also about themselves, because many of them felt like they had questions and concerns about. They also felt like you should really be assessing this kid's knowledge about a lot of the aspects of diabetes. And then in terms of interacting with the psychologists on the team, there were very positive views about all of that. Mothers felt that psychology consultations were not frequent enough and that the team should provide them regularly, recommending that endocrinologists verbally offer the psychology consultations to patients at every visit who wants them. Of course, we don't have the capacity to be able to respond to that, but that's what they want. And then in terms of accessing mental health outside of the clinic, this was a really important issue. And I'm sure you are all dealing with this when you do screening and kids are screening positive. What do you do then? Now you have an obligation ethically to kind of address that issue and try to figure out where they can get those services. They needed help, families did, in navigating the emotional side of diabetes. Mothers were willing to seek mental health services outside of the clinic if it was recommended by their doctors to do so, because they really believed that the physical and mental health were strongly connected. But a lot of them said they would be unlikely to seek mental health if they felt that the providers in the community didn't understand diabetes. And one mother said, I thought this was very right on. She said, I find it very tiring to go to a generic psychologist and have to spend the first few sessions teaching them about what diabetes is. So they clearly don't want that. And, this is one of the good things that I think in the last several years, we've been addressing nationally by having the ADA and the American Psychological Association team up to have an education program for psychologists to bring them up to speed about diabetes management so they can be more effective. And accessing these services outside of the clinics, again, there were a lot of barriers, mainly about financial issues and insurance issues and finding time to schedule appointments, and even stigma, which still is an issue, despite the fact that we can talk about it routinely. Mothers recommended that physicians should educate the families about the benefit of therapy and connect this from the beginning of the child's diabetes, from the day of diagnosis even, to normalize mental health services as part of overall services. So families want their providers to address mental health as part of routine care. Screening is accepted and valued. There are some important barriers, and the screening should include psychoeducation, knowledge checks, and as parent reports. We actually did initially have parent reports as part of this, but parents didn't typically complete the screeners themselves. So we ran into issues there. And we need, we are now doing more QI type efforts to try to pilot some new approaches to that. But families need help connecting outside of clinic as well. Now, during COVID, of course, it affected everybody. It affected the way we practice. And what we saw immediately after COVID was a big drop off, of course, in screening and consultation from our psychologist. So we had to really kind of regroup very, very quickly. We just published this data in the last year, I think, in the Journal of Clinical Psychology in Medical Settings. And it really was a QI study. So what we did was identify the fact that we had declining screening completion and declining consults with the psychologist as the big challenge following the shift to telehealth. So we did a PDSA type quality improvement framework to improve screening and consultation. Initially, they dropped, of course, but they recovered to nearly pre-pandemic level following 3 cycles. And I'll describe those cycles in just a second. During the implementation, there were a lot of challenges about the feasibility of doing this, about how our team operated, how we can engage patients, and there were ethical issues that came up as well. So the first cycle was really, the team decided, well, we got to give the caregiver a time-limited link that could be emailed to them. And then the physician would then refer the families to psychology who could then contact the caregiver via phone to schedule a telehealth, which you needed additional consent for. Well, that sounds a little cumbersome, right? So as we found out, that didn't work really well. In the cycle 2, a month later, because we still had insufficient screening, the team called the caregiver, and the healthcare team was given a list of all the patients that were to be screened so they could remind the family during the visit if the screener was not done. And the team sent an email to, or actually, I think it was Dr. Sanchez who sent an email to the entire listserv of the clinic population, letting them know that about mental health resources and the psychology team contacts and all that to get it out there. And that helped a little bit. But then we went into a 3rd cycle a month later after that, where we had a significant thing happen at our university, which was that the EHR was updated and allowed virtual visits with Zoom integrated into Epic. And then that gave us the opportunity for virtual warm handoffs. Doctors emailed the psychology team to join the medical visit, and then they kind of went off and the psychologist continued the visit. And the other thing we did at that point, another month later, was to use generic links sent to the family, the caretaker, several days before the visit with links that didn't expire. So it gives the family a little bit more time to do that. Results, I told you initially we had like an 83% screener completion rate, but that was in the first year of the program. We did not re-screen kids every time they came to clinic if they screened negative. So what our base rate around that time was around 65% or so of kids were completing screeners. And that makes sense because they may have screened positive the last 2 times or 3 times. And our consultation rates were around 30%. But that dropped off in the first cycle and continued into March and April. And then in cycle 3, you can see it bumps up in terms of consultation and screening. And you kind of ended up by August almost at pre-pandemic levels. But that only happened because of the quality improvement framework that allowed us to evaluate what we were doing and plan and make changes and be flexible. What we really learned from that was that when you shift to a consultation service, basically, with using telehealth, we really need to communicate well with our team to get perspectives from everybody and to leverage the electronic health record, as well as developing these procedures for warm handoffs and navigating ethical issues. What's the ethical issue I'm talking about is the suicidal question. If you send out a screener that assesses suicidal ideation, and then you're not around to respond to it for 3 days or 4 days, or you may, that's kind of not a good position to be at. So we ended up deleting that question, keeping the depression questions, but deleting that. And then if they're depressed, then following up in person or in person or virtually. But speaking of leveraging the EHR, I really love this. Dr. Lee, I think you're here somewhere, but the 6 habits and building that into the record is really, really important for facilitating this work. And of course, these 6 habits are all about glucose monitoring and insulin use. But I thought this was terrific. For every unit increase, 1 unit in total habit scores, there's a mean decrease in A1C among all these participants. Fabulous data, but only 8% perform all 6 habits. So we all have a lot of work to do in getting these habits and other habits. I did notice, I don't know if Dr. Crothers is here, but this was screening surveys for all the clinics in T1DX, and this was reported just a few months ago at ADA, but was data collected in 2021. And in the pediatric centers, 96% were screening using at least 1 tool. So that's happening. 79% using 2 or more tools. Interestingly, adult centers were not quite up to par with the pediatric centers. Only less than half were using 1 or more tools. But of course, the most common screen is depression. That's the thing that seems like everybody at least is focused on that. But of the pediatric centers, 40% are screening for transition issues, social determinants of health, anxiety and diabetes distress. The common challenges, which we all know, are time constraints, workflow integration, and how best to follow up on positive screens. So in summarizing, and I'm probably on target for summarizing, I'm over target probably, I'll be very quick to finish up. I want to address these 3 issues very quickly. Barriers to achieving good glycemic control. We know it. Stress, anxiety, depression, family conflict, low motivation, regimen adherence problem, particularly think about the 6 habits, particularly about not just if you're using CGM, utilizing CGM, looking at the data, understanding where the issues are and where the problems are, and then coming up with plans to do it. So utilization of blood glucose data, I think one of the first studies I ever published was in the 80s, was a simple study really of surveying kids and families, what they do with the results of their blood glucose checks. And what we found was like nobody was using it to make any decisions about anything. They were just doing it because they were told to do it. And then half the time they were falsely doing it and reporting that they did it. So this is still a big issue, utilizing. And then the other, of course, is omitting or underdosing of insulin. Those 2 behaviors are behaviors with great impact, I think. And of course, lack of integration of behavioral medical care is a major barrier. Barriers to youth receiving behavioral health care. We still have to deal with that, attitudes and stigma. Financial barriers are still present. I don't know how all you guys are managing this in your clinics who do have psychologists, how they get paid, how many you have. I mean, if we have 15% FTE for our clinic, that's not enough. to do what we need to do, but it's something, and we're grateful. We want to be there, but, we need more. In many states, insurance coverage is, particularly for low-income children. Here in Florida, it's a big issue because Medicaid HMOs are controlling behavioral health services to poor kids. But the HMOs provide such poor reimbursement that you don't have very good providers or very many providers that are in those networks. So the bottom line is most kids, particularly the low income and ethnic minority kids, do not receive evidence-based behavioral interventions to improve their care through management. And finally, that brings us to the integrated behavioral health care issue itself, which I think will overcome these barriers related to behavioral health care. We know, we have data. There's a great evidence base for this. Behavioral interventions can reduce medical utilization, can reduce DKA hospitalizations for youth who have poor A1C or DKA, et cetera. These studies have been around for almost 20 years. Integrated psychological services in diabetes clinics improves subsequent glycemic control and reduces costs. This was a study just published in 2020. And sometimes this research gets published in journals that not everybody in the diabetes field is going to read all the time. So in this case, it was the Journal of Clinical Psychology in Medical Settings. But it was a good study, and it's worth, kind of repeating the message. If you do involve psychologists in routine ways with your patients, they tend to do better over time as part of an overall approach that recognizes the importance of psychosocial issues. And the bottom line, again, here, I think, is we need more research to demonstrate cost effectiveness of integrated approaches with kids with diabetes, because ultimately that's what drives policy changes. And it could make changes in things like Medicaid reimbursement rates and, and so on. So I hope, I do want to recognize the members of this team. Eileen Davis, our psychologist for the last 6 years ago, I guess, until last year. Caitlin Brodar, who was a terrific psychology graduate student, and some of the work I just reported was based on her dissertation. It was some of her dissertation work, the qualitative studies. We had a few interns that we're working with, Dr. Sanchez, of course, Annette LaGreca, one of my colleagues in the psychology department at University of Miami, and our newest member of the team, Louisa Mali, who is a psychologist that's been the team psychologist for diabetes in the last year. I want to thank you for your attention, and I hope that over these last couple of days, you at least have a little glimpse of the good weather we have sometimes in Miami. Right now, we're under threat, as you know. Never too late for a little hurricane, even in November here in Miami. So I hope that you all enjoy the rest of your time and safely travel home. Thanks so much.
We're going to do just 2 questions, and then you can chat your questions, Zoom, or let us know, and answer them later. If there's any questions.
Thank you very much for the talk. I'm from University of Utah and Mountain Foundation Consulting. What advice do you have to advocate for funding for integrated behavioral health and diabetes clinic, or have there been situations where the psychologist has been supporting?
Yeah, good question. I mean, in our case in Miami, we have at least for the lower income kids, Medicaid, and we have something, a health insurance for Medicaid eligible patients called Children's Medical Services in Florida. So we have a contract with them that includes that 15% effort I was talking about, but not all of our patients have, CMS, and they have commercial insurance. And if we are spending a significant amount of time working with the family and clinic, then we do submit a bill to their insurance company. So that's one way we can kind of recoup. And we have to advocate for, essentially, for these services. So we inform families of that. The families have been notified. A letter from Dr. Sanchez has gone out to everybody on the listserv, and they know that they may receive a bill from the insurance company from their work with psychologists. The larger issue you raise is how do we deal with this more systemically? How do we advocate for that? And, you know, in a way, it's kind of, it's the work of advocacy that we as healthcare professionals have to engage in. And that what's going to drive policy change is letting people know who are in positions to influence that policy. And some of my work was around 8 years ago, I guess I was working with the Society of Behavioral Medicine on their board. And one of the things we did after our annual meeting in DC was we had Hill visits arranged where we went to the Congress and Senator offices and had everything prearranged, you know, and we went there with fact sheets and hand things out, and we advocated for here's the sorts of things that we think should be done. So part of it, you know, involves concerted efforts from professional organizations, and I would say T1D Exchanges is a professional organization that could do more of that if you guys do have advocacy initiatives to influence funders, politicians who ultimately affect how funding is made. Otherwise, it's up to us to try to figure things out. I mean, a lot of people will go after some grants like HRSA grants, or NIH grants isn't exactly what you need for the type of work we're talking about, but there are other opportunities, but that makes it difficult because grants are hard to get and not everybody knows where to go to get them. And so here we are struggling. How do we fund?
Thank you. We have one Zoom question. Who scores the screeners and initiates behavioral health consults?
So first of all, they're automatically scored with a algorithm that's built into our program, our screening program. So it's on a laptop, not a laptop, it's on a tablet. And as soon as the family, the kid or the parent finishes, they submit that, it gets automatically scored and we get a report. Now, our psychologist is the one who organizes and manages that aspect of it. So the psychologist gets a report, sends it to the team who are during that clinic, who are going to know about whether or not the kids have exceeded the cut points and in what areas they exceeded cut points. The physician is going to make a recommendation to the family that, hey, I'd like you, you know, maybe they're going to each do it a different way, but they essentially have that information, talk with the family about it and say, I'd like to invite my colleague in, Dr. Mali, to discuss some of these issues. Is that okay with you? And then that's how we do it. We, you know, since COVID, it really did disrupt everything. I think we had a much better, and I'm sure you all can relate, we had a much better in-person, you know, huddling in a room together, talking more, being able to kind of chat with one another. But now it's a little bit different. Most of our patients are back to being seen in person. But our psychologists are still sort of waiting to be called in. And I don't think it's the ideal way to do it, frankly. I think if we had more support that could support more psychology efforts, then we would be able to see as many kids as we possibly could. Yeah.
Thank you.
Okay.
We're going to head out to the breakout session.
Thank you. Okay.